is Magic of SICS 1, which will be followed by SICS 2. And these two are very interesting sessions since years together at AIOS. And all the crowd which is gathered over here is interested in SICS activity, maybe in dual minds, PHECO, SICS, or both of them, pros and cons, positive and negative aspects of both the procedures. Now I invite Chairperson Dr. Jagannath Boramani, who is with me. Big round of applause for him, the man who has taken ISMSICS to great heights. Then Co-Chairman Dr. Debashish Bhattacharya ji, moderate, yeah, please sir, welcome. Past President AIOS, the man who has taken SICS in western part of India and everywhere to great heights. Then Dr. Usha Johri. Then I am Dr. Prakash Marathe, Dr. Shatanshu Mathur, is he here? And Dr. Srinivas Joshi. Okay, so welcome everyone. And we have our founder president, Dr. Sahu sir here. Because of him, ISMSICS chapter, not only in India, not only in all states of India, but internationally, he has taken the moment of SICS at great heights everywhere, starting from America, Thailand, Mexico, and everywhere. With all these words, now I invite the first presenter of this session, that is Magic of SICS, Dr. Neeta Dodwad, will be speaking on perfecting the scleral tunnel. I think most of the speakers in this particular session are new generation speakers, and definitely you will be hearing something new from them. In between, comments by Dr. Jagannath Boramani sir, Dr. Debashish sir.
Yeah, obviously from beginners, incision is perhaps the most important thing, and which Neeta is going to take up, perfecting the scleral tunnel.
A very good afternoon to one and all. At the outset, I would like to thank Dr. Sahu sir and Boramani sir for giving me this excellent opportunity. And very special thanks to Dr. Boramani sir for providing his surgical videos and animation slides for the presentation. Today I'll be speaking on perfecting the scleral tunnel. The magic and the beauty of SICS lies in the perfectly constructed scleral tunnel, which is self-sealing and watertight in nature, which facilitates the smooth delivery of any grade of the nucleus, giving least amount of SIA, and at the same time correcting the pre-existing astigmatism. So to have a perfect visual outcome, proper planning is required in individual case. So well planned is half done. The concept of scleral incision was introduced in way back in 1983 by Richard Katz. Before going into the main scleral tunnel incision, few important preparation points are proper anesthesia, stabilization of the globe, minimal conjunctival periotomy, and minimal cautery. Variables of the scleral incision are location. Location of the incision could be superior temporal, or temporal. Superior site is preferred for the ease of execution and exposure. Width of the incision is nothing but the distance between the internal and the external incision. The depth of the incision should be half thickness of the sclera. Size and the shape of the incision depends on the grade of the nucleus. The first figure shows the curvilinear or smiling incision, which gives the maximum wound sagging and hence the increased astigmatism, so it is not advocated. The second figure shows the straight line incision, which gives a little sagging and minimal astigmatism, so it is one of the preferred. The astigmatic effect of a smaller incision, which is nearer to the optical axis, is similar to the larger incision, which is away from the optical axis. But doing the steps at this posterior side becomes difficult, hence the concept of frown incision came, where the central part of the incision, which is near to the optical axis, and the edges of the incision are away, so giving a minimal astigmatism. In frown incision, chevron incision, and one of the other popular technique is Blumenthal. So what are the components of the scleral tunnel? One is the external grooving or external incision, scleral dissection forming a scleral tunnel, and entry into the anterior chamber giving an internal incision is normally larger than your external incision. So this is the diagrammatic presentation of the triplanar incision. External scleral grooving is done. Scleral dissection done in half thickness. Here, important is the direction of your crescent blade should be parallel to the sclera. Once the dissection is proceeded at the clear cornea, the direction of your crescent blade should be parallel to the cornea. And at the time of anterior chamber entry, the direction of your blade should be parallel to the iris. Hence, the corneal wall created by this gives the self-sealing property to your incision. In this video, we'll be seeing the external frown incision. Mark the incision is done 2 mm posterior to the limbus. By sweeping movements, once you get the correct plane of the incision, see what is the depth of the incision. This is judged by the visibility of your crescent blade knife under the sclera. Once the dissection is completed on one side, by sweeping movements, the dissection is done at the other end and the scleral pocket is confirmed. Here 2 important points are, the clear corneal incision should be at least 1 mm into the cornea, and throughout scleral tunnel, the single depth has to be maintained. And while doing anterior chamber, go at the corneal end, see the dimpling and enter parallel to the iris, and cut the corneal lamella when you're moving forward. So while doing the construction, if you're superficial, there may be a scleral buttonholing. And if you are deep into the sclera, you may have a premature entry and iris prolapse. And at the end, it is very important to check the wound integrity. In case of a doubt, place a suture or a 2. Patient's vision is more important than the surgeon ego. Though the scleral tunnel considered a difficult step can be mastered by the patient's positive attitude and practice by way of a simulation training, wet lab training. If nothing available, just go vegan way. Your onions, banana, you can make a number of the scleral tunnel. Thank you for your patience hearing.
Thank you so much for the wonderful presentation. Now Dr. Usha Zori will be telling us about all the speakers in short. Yeah.
A very good afternoon to all of you, and I'm sorry for the delay, and I'm sorry that I could not introduce Dr. Neeta Dudwad. Can you just show the presentation, please, of the introduction? Yeah. Sorry, I'm introducing you after your talk, but your talk spoke so much, good about you, and you did such a wonderful job. AIOC ISMSICS, yeah. So I think Dr. Neeta Dudwad after her talk doesn't require any introduction, but still, just to complete the formality, I shall do it. So once again, once again, I welcome you all, and let me take the privilege of, introducing Dr. Neeta Dudwad, who is a medical director at Brahmanetralaya, Bombay, and Rotary Club of Mumbai. She is a consulting surgeon at Prasad Chikitsa Ganesh Puri, and she has worked in various prestigious institutes, SICS, phaco, retina, oculoplasty, lots of, I think she has, taken the she has done the fellowships from various institutes, and now I think she has decided that I think SICS is her area of interest, and of course she is also the joint secretary of the women's wing of ISMSICS. Thank you, Nita, for your excellent presentation. So, her topic was perfecting the scleral tunnel. So, our next speaker is Dr. Rakesh Shakya. He's also a senior consultant cataract and head glaucoma services from the most famous institute, I think, doing a lot of good work, Chitrakoot, Sadguru Netra Chikitsalaya, Satna, Madhya Pradesh. And he's an expert in MSISS simulator, and he's a reviewer, Amsterdam, the Netherlands. Welcome, Dr. Rakesh Sakya. And he is going to talk on safe 2-minute SICS. I think this is the mastermind of none other than our chairperson, Dr. Amulya Sahu, who has trained many of us this technique. The third person who is going to speak is Dr. Kimaya Chavan, and she's also a consultant ophthalmologist from Mumbai, and she is currently a brilliant teacher, teaching many of us, she's an instructor on the simulator Help Me See. So, and she's going to talk on her favorite topic, that is simulator training for SICS. Then we have Dr. Pranav Kodiyal, a consultant in a very beautiful seaside tribal area of Dhanu, a very intelligent person, but his passion is for writing and is a published fiction author and haiku poet. I really don't know what this haiku poet is, which I think you should explain me a little later. And he's going to talk on endo expression of nucleus. Dr. Purvi Bhagat, I think, is a brilliant surgeon, a professor, doesn't require any introduction, a glaucoma specialist from Ahmedabad, and she's done an international fellowship in medical education, FAIMR, and she has a passion for teaching, and her resume is so big that I had to cut it down. Thank you, Purvi, for coming here. And her topic is going to be MSICS, myriads of variations. We have Dr. Pavan Kumar with us, who is going to talk on tips and tricks for safe SICS. And Dr. Jatinder Bali, who is the Chairman Research Committee of ISMSICS, Chairman DOS Subcommittee, and he's an author of many books, but just to name a few of them: Basics of Biostatistics, Tips on Retina Practice Series, and Basics of Glaucoma. So he's going to talk on understanding economics of SICS, which is so important, and we have gone through this during the COVID time. And the next speaker is Dr. Jagdish Reddy Bandi. He's a very well-known consultant from Hyderabad, clinical director of Iswar Eye Hospital. And other than ophthalmology, I think his passion is a very creative person and a very humble and a very an excellent orator, I must say. So he's going to talk on global SICS training program by ISMSICS, and he's our global director. Next is Dr. Aman Khanna, who's done his fellowship in SICS, FECO, UVA, Retina from Sadguru Chikitsalaya, Chitrakoot, a very well-known institute which all of us know, and is currently a consultant at Khanna Eye Clinic, Eye Center, Delhi, and he has presented various papers at a national and the international level, and his area of interest is retina surgeries along with the management of UIT cataract. So with this, and he's going to talk on tackling hard cataract for colobomatous eye, which is, I think, an extremely difficult topic, and we would love to hear from him what he has to say, and we'll learn from all these speakers, young dynamic speakers, and the take-home message is, I'm very happy to see that the hall is full in spite of the time, which is 1:30. So over to you. Over to you, Dr. Rakesh Sakya.
Yeah, all of them had their lunch.
Yeah, Rakesh is here.
Dr. Rakesh Sakya.
So, good afternoon to all, and especially Boramani sir for giving the opportunity, and Amol Sahu sir, and Bhattacharya sir, and every Sudhanshu sir also, and every chairperson. Good afternoon to all. So, my topic is in the short and sweets. I'm talking about the how to do the MSICS in the 2 minutes.
In Chitrakoot, they do 1 lakh surgeries a year, and this hall is short because the trade figures are that 18 lakh PMMA lenses out of 65 lakh cataract surgeries done annually. So essentially, straight away, 1/4 of the cataract surgeries are definitely SICS, and we have only hall H. Anyway, never mind, let's go ahead. Rakesh, carry on.
But I will request all of you not to follow him blindly, 2-minute surgery. You take your time because you do not have so many surgeries to do.
No, it comes
We have
with
hardly
time.
10, 20 surgeries in
They
per
have
day.
operated live
So
in my
just
place.
listen
I
in
have been to
carefully
Chitrakoot.
and see.
It's
Don't
a
follow.
wonderful institution to understand and follow.
I would like to slightly disagree with what Satanshu sir said, is because if you start doing surgeries in 2 minutes, then you'll have more time for other patients. So your output also starts increasing, sir. Of course, in a safe hands. This is just to be taken.
Patient do not pay you money if you send him out in 2 minutes. We have to ask him to sit in the OT area for 15 minutes, then now you will be paid easily. For 2 minutes surgery, nobody is going to pay you enough money. So, Rakesh, are you ready? Rakesh, ready? We can call another we can speak later on. Otherwise we can call later other surgeon.
So actually, the cataract surgery, as you all know, that this is not an emergency surgery. So why to actually want to do the cataract surgery in the few 2 to 3 minutes? So in the developing country like us, the large population of large populations where the unmet need of the cataract surgery is very high. So the 9 to 12 million people are blind, and 50 to 80% are due to the cataract. And every year, 3.8 million people actually are added for the cataract surgery. So why this region we demand a slightly cost-effective and fast and reliable method? When you are working in the high volume center, you want slightly fast surgery. So now I am going to talk about this is my unedited video, view video. So as you see, in our hospital, they are the actually the waiting area where there are the many camps and where they are the many patients are waiting for the surgery. In winter season, sometimes the 2,000 people are admitted for the surgery. So the volume is there, no problem. So initially I make a side port and then put the visco. So I just deepen the chamber. So after that we tighten the bridal suture and make a conjunctival peritomy. It is about 6 to 7 mm. And then hold the tenon with conjunctiva and make a France of incision. And after that, with the help of the crescent, and it advance into the cornea, make a small side pocket, because this is the cataract is not hard. So after that, with the help of the 3.2 keratome, cut in inward direction up to the side pocket. And then with the help of the atrata forceps, used to make a capsular axis after putting the some amount of the visco. And the hydrodissection is done with the help of the hydrocannula. Sometimes the cataract is very soft, so you can just prolapse the nucleus in the antechamber with the help of the hydrocannula. And then put the visco over and behind the nucleus and deliver with the irrigating bacteria. And then cortical removal done with the Simcoe. The remaining part of the cortical matter I always remove from the side port. And then oil implantation done under the hydro. So we keep the Simcoe cannula in the side port and leading haptic in the bag, and then dial with the Sinskey hook. So this surgery is completed less than 2 minutes. So actually how to develop this skill safe SICS in 2 minutes? Because we have the very training protocol is very good, and we have the 26 modular theater and very good actually the bat lab in our hospital. So we have the 3-year program. In the first year, actually we actually do the how to make a tunnel in every step. And then after the sometimes surgeon will follow the same steps. So this is the few steps, like I make a side port first, and then conjunctival peritomy, and after that incision. So just adjustment of this steps, so you can do the surgery slightly fast. This is not a one day actually practice. This is requires more time to actually practice like that. But this is our hospital, this is slightly need to do the surgery slightly fast. So in the chances of the extension this high, so I actually run before the extension sometimes. But when you are operating the slightly complicated case, it require the more time. With the same technique actually applied. So the cortical is sometimes the adhere to the PC. You can actually polish with the help of the Simcoe cannula, and then put the lens in the hydro. And after that, we putting the some amount of the antibiotics, moxie, and then subconjunctival dexamethasone. And that they automatically the conjunctiva is opposed. So during the training period, every surgeon follow the same protocol. So gradually with the time, surgeon develop this skill to do the cataract surgery fast. In the winter season, we have do about the 8 to 1,000 surgery in a day. Because we have the more senior person and fellows. Thank you so much, sir.
Wonderful, wonderful surgery, Rakesh sir. Sir, one point. Yeah, go ahead, Amul sir.
We are promoting not to use the brittle suture. Now you are showing use the brittle suture. They will be confused. If you are doing it, do not have an extra advantage except a mask surgery when you are doing. You want a superior incision. We are giving an estimatic steep axis. So much of, if you want to do a quality SICS surgery, I don't think brittle sutures should be advised. When you
I agree with you, sir. I agree with you. Sometimes we are actually practicing without bridal suture.
Yeah,
Thank
nice surgery. I think you have to put a disclaimer, sir. This has to be done only by few surgeons and not to be attempted by all. That the statutory warning has to be put in. And another important thing what I noticed is, should we spend a little one more minute on doing the PC polishing?
Yes.
Because in most of these cases what I saw, there were a little bit of remnants left and there are high chances of PCO. We would also like to know your PCO results in these 2-minute cases. That will definitely give us more and more insights.
Yes,
So would
definitely.
you advise a little more spending time, especially on the PC polishing? I just wanted to-
Definitely, sir. Definitely, sir. Thank you.
Two more observations. One, in your first case, when you were aspirating the cortical better, there was a stress on the posterior capsule. We could see the folds. So in a hurry, is there any more chance of PCR? Number one. Number two, while doing your second surgery, just after pushing the IOL, you have removed the cortex, but you have not taken care of the subincisional cortex. And you have also not removed the visco from the anterior chamber. You have not, even
Actually,
you should have
I
removed the
always- no,
visco
I-
from the posterior, from the backside of the IOL also, but these are my observations.
Actually, I always put the
Visco is not used.
IL in the hydro. So actually the all visco is removed. I think I did not see in my cases, in a few cases, IOP spikes there.
No,
but not.
just a moment.
Sir,
sir.
second case,
Yeah.
there was visco in, around.
Could be from the Rexis stage because he was, this is a very good idea to give the lens in the, by infusion. The second thing, observation in that, to what you said, Srinivas, is look at the size of the Rexis. So, when you are doing a 7 millimeter, it's a possibility. You can do a 7 millimeter Rexis. You reach the equator as such. Plus, the Rexis fuses beyond the PMMA, and that cuts off, the LE cells. And so I would always say, Chitrakoot, they work in a very defined territory, say 5 districts, I think. So they will get, there are no YAG lasers in that place. So they get back everything, and I don't think their YAG laser rates must be more than 10-15%. Which is standard with PMMA.
Thank you, sir. Thank you. It is about in the 70% cases, the one, less than 1 or 1. Yeah, in the 70% cases, not 30% cases, yeah.
I have a question for the ma'am who presented earlier on. Scleral incision and in pocket formation, how close you go to the limbus? Because now people are going very, very close to the limbus. It is almost a corneal incision, almost a corneal incision, number one. Number two, people have stopped doing peritomy and cauterization of the vessels. Straight, they will make an incision, go for the corneal tunnel, enter the chamber and perform the surgery.
Yeah, many people are doing without a conjunctival cut, but if you are doing in a mass, conjunctival peritomy is better, it will cover. And at least you should be 2 mm away from the limbus. It depends on the grade of the nucleus. If your incision size is bigger, little posterior is preferred, and the different incisions like the frown incision or the horizontal near 4 mm and the cuts like Blumenthal technique, you can be 1.5 to 2 mm away from the limbus.
Dr.
To
Kimaya?
me, straight incision has all the advantages. What is your experience about that?
Straight incision, again, if the length of the incision is more, it will get a more astigmatism. If the grade of the nucleus is softer, it can be smaller.
Nepal, sir.
Thank you, thank
We'll
you.
take all the-
So one request, because the hall is full and we have so many speakers, I request from the audience one question after each speaker. Otherwise, we cannot complete. There are so many interesting topics.
better
In the
take-
interest of all the people, I request you all to
Srinivas.
ask at least minimum one question. If
No,
not,
Dr.
then we can
Srinivas.
take it at the end.
Talks are only for 5 minutes. We'll
Yeah.
take questions only at the end, only if time permits. Otherwise, the last speakers will be left out.
Yeah.
We
So
have
I
to
now
close down
call
at
upon
4:25.
our next speaker, Dr. Kimaya, who will be presenting in place of Dr. Manek Nicholson. She'll be presenting on the magic of, simulation training for SICS.
Okay, good afternoon everyone, and my regards to everyone on the dais, and special thanks to Dr. Sahu sir and Dr. Boramani sir to give me such a beautiful platform. So I'll be talking on simulation training in SICS. So basically it is important for those who have got very insufficient surgical training, like in COVID time every one of us knows. Of course, to learn a better handling of the instruments, to achieve perfection in a particular step, shorten the learning curve, and also to have least surgical complication in live surgery. This Help Me See simulator is the only simulator available to rate. It has high fidelity, 3D virtual reality with tactile feedback. That means you can feel the tissue. This is how the simulator looks. It has the eyepiece same like our operating microscope, where you can adjust the IPD as well as refractive error. And it has a screen attached to it, from where I will just tell you how to do it. These are the handpieces or the haptics with wings. Basically, we use this for the surgical process in the simulation. This is a touch screen with which we choose particular step we want to perform, and also the instruments which we require to perform the surgery. In Help Me See, we are actually dividing the surgical steps in 4 modules, and we have actually 12 simulated steps. Now I am going to show the interesting part, how we approach. We are making the groove now with the crescent. You can see the surgical tools on the screen. Now we are approaching, now we are going to make the tunnel. You can see the IOP variations when you are making the tunnel also. So this is how we are making the tunnel. Now here we are proceeding and making the paracentesis with a 15 number stab blade. We have to just change the instruments which we select from the screen. So this is a paracentesis. Now we are going for viscoelastic injection. And now we'll proceed with the keratome entry. The green line shows the inner limit of the tunnel from where you have to enter with the keratome and complete the entry in SICS. Now we'll be proceeding towards the CCC. The most important part and the most difficult part for students to perform. So here we take a cut, inverted C or J-shaped cut. We make a flap just like how we make it on our normal surgery, routine surgery, and proceed same like how we do it in the live surgery. It's very beautiful to see because you can feel the texture of the capsule even. So the simulation is actually very, very near to normal. Now suppose you have a complication, okay? So the screen will show you and the cystosome will turn red and it will show you the tear run out on the screen itself. Now we'll go with the hydrodissection step. Here we have chosen the saline syringe as an instrument. Now we are performing the hydrodissection here. See, the nucleus turns up. It's very, very beautiful. And now we are having nucleus dislocation. We use Sinski hook here as an instrument. We go inside and with cartwheel fashion, we are turning the nucleus up and it will be in the AC. Okay, now this is my favorite step because it looks very, very original. So we use here wire vectis and we are engaging the nucleus here. With the colibri, I am giving the pressure downwards and yeah, here the delivery is complete. So now we'll just see how the cortex removal is done. Here we use Simcoe. We have even from the side port entry also. Here I am showing you from the main tunnel itself. This is how the cortex aspiration looks, very, very beautiful, as original as it's required. Now if you have a complication in Simcoe, it will be seen like this, capsule aspiration. Also, like zonal breakage, if you are being very harsh, it can be shown there. Now we are inserting the intraocular lens in the bag. Here we are using McPherson. Now we are putting the lens in the bag and you can see the red dot by showing that the lens is in the bag now. So even that is been taken care of in the surgical tools. So now in future we are actually completed the module of complication management where we have dialing of the ACL in the AC, sphincterotomy and also the CTR, and even we are be launching phacoemulsification module in 1 or 2 months. So in training we are actually giving the students ebook to self-study. We are taking the classrooms of the students because they need to have the basic concepts clear. We have lab activities on tomatoes and potato peeling. Also we are giving simulation hand-based training and debrief sessions. Thank you so much for the patient listening. Thank you so much.
Thank you so much, madam. It was like a aviation simulation, you know, where you can even, yeah, wonderful machine. I think you all should experience it once. In the interest of the time, we'll go ahead with the next speaker and then we can have discussion a little later. I now call upon Dr. Pranav Kodiyal. Yeah. So he'll be speaking on the endo expression of the nucleus.
Yeah, that's the one. Good afternoon, everyone. A heartfelt thank you to AIOS and Boramani sir, Sahu sir for giving me this opportunity, and also to Dr. Boramani for sharing his images and videos that I've used for this presentation. I also thank Dr. Boramani for inventing this wonderful technique. No financial disclosures. Let us take a moment to remember Dr. Kunwar Vikram Singh Dhaliwal, an excellent surgeon who demonstrated this technique many times. Unfortunately, he passed away at a very young age, and this was a great loss to many of us on a personal level and to the world of SICS in general. It was Dr. Dhaliwal who coined the term nucleus endo expression for this technique. Traditionally, in SICS, nucleus extraction involves the use of hydroexpression with the AC maintainer and irrigating vectis or visco expression. This is regarding the pushing techniques. But sometimes we are confronted with the Bahubali of cataracts, also called as the grade 4 hard nuclear cataract. At this time, we have to invoke a divine superpower. We have to invoke the Rajnikant of all nucleus expression techniques, also called as nucleus endo expression. Here is a superb video demonstrating the technique. Note the exquisitely constructed U-shaped incision with a deep side pocket dissection. This causes a snake's mouth effect to allow it to engage and accommodate a nucleus much larger than the size of the incision. The incision here is just 5.5 millimeters, but I've seen Dr. Boramani bring it down to less than 4 millimeters. We bring the nucleus into the anterior chamber. Then depress the posterior lip of the incision to engage the nucleus within the incision. We insert a SICS hook inside the anterior chamber and push the nucleus out. We can also use that SICS hook within the incision and from outside to cartwheel the nucleus out of the incision. Another elegant demonstration of the technique. The incision here is nasal, but you can also use a temporal incision with this. The surgeon here has used the additional horsepower of an AC maintainer. You can also use a sheets glide. I prefer to use viscoelastic because it offers better corneal endothelial protection. Lifting the incision also helps in this step. Even in the movie Sholay, when Gabbar Singh overwhelms Viru, he takes Jai's help. Similarly, we can include phaco-fragmentation, which lends additional muscle to our technique. Similarly, here see, this cataract, the lens is very hard and very large and gets stuck in the incision, and it's very difficult to remove it. So what we do is we use the SICS hook to chop out a part of the nucleus. We then push the nucleus back inside, reorient it with its longer axis pointing towards the incision, and then express it as usual. The SICS hook going inside again and pushing the nucleus out. After seeing these videos, you might be concerned about the safety of the corneal endothelium, but relax. As you can see, all our wrestling with the nucleus occurs inside the sclerocorneal tunnel, and the amount of damage to the endothelium is much less than you can imagine. The advantages, of course, of this technique is to take out a hard nucleus through a much smaller incision without the risk of nucleus drop, as with phaco. The disadvantages, especially with beginners, is damage to corneal endothelium and iris and hyphema. But if you take precautions with shallow AC and hypermetropic eyes, use lots of viscoelastic, avoid iris entrapment during nucleus expression, you won't see that much post-op corneal edema or iris damage. Thank you for your kind attention and patient listening. I hope you try this wonderful technique. I think you'll like it. I hope to see you all at this conference in November. Please do register for it at the ISMSICS booth next to the My Healthscape stall in the trade area. Thank you.
Wonderful presentation. Thank you so much. Before Dr. Purvi madam just puts in, is there any special instruments you ask us to make an endo push, Purvi madam? I request our next speaker, Dr. Purvi Bhagat, to please open her presentation.
I'm so sorry. Can you repeat the question?
Any instruments you would like to suggest to make that endo push?
Yes, Dr. Boramani has used the SICS hook, but I think an iris spatula, if you are a little afraid of hitting the corneal, hitting the PC, you can also use an iris spatula. So anything to add?
No, nothing. I use iris spatula also many times, which is used for depressing the scleral lip, and the same spatula you can put in the side port and push the nucleus. What your disadvantages he has told is only when you don't take proper precautions.
Yeah, agree.
Sir, you feel more safe with endo expression or phaco?
I don't do phaco. I stopped doing phaco.
No, not phaco. Phaco dissection. Phaco dissection. I mean, making the cut of the nucleus and delivering it.
He is telling phaco fragmentation.
Phaco, yes, phaco fracture.
Fragmentation. See, try to push the nucleus through the scleral tunnel, depending upon the hardness of the nucleus and the elasticity of the sclera. You don't know whether it is going to come out total or it is going to get fragmented in the sclera.
Correct. Thank you.
No, if you are used to viscoelastics, there was one video with Pranav, but because of shortest time he has not shown it. You can do it under visco also. Dr. Vikram used to do it with visco.
Next. We'll take the questions in the end, sir. Sorry. Yeah, Purvi madam, please.
Yeah. So good afternoon, everybody. And I'll be talking on a slightly different topic, a myriad of variations which exist in manual SICS. SICS has seen a long history. It all began in 1980s when it was recognized about the role of a self-sealing scleral incision followed by the Blumenthal's technique. And then there were lots of variations and the snare came up and Fico fracture and to the current role of 2 millimeter, 2 minute and the smart software based SICS. But if we see in the entire history, one technique has not overtaken any other technique. All of them are parallelly still coexisting with each other and all of these techniques are well practiced globally. So we understand that there are a lot of variations in the MSICS technique with respect to the technical steps, with respect to the surgeries overall, with respect to the surgeon's preference, and therefore the training programs that exist with MSICS. So therefore we did a study where we analyzed the different MSICS practice patterns across various geographical regions of the globe. And we studied the type of anesthesia and the preferences for each and every step of MSICS. So I'll just share with you all those results to understand this myriad of variations that exist. Through a questionnaire that was floated globally through various media, we received 278 and valid responses which could be analyzed, out of which 68 were from 13 foreign countries and 210 were from different zones of India. So let us see what these variations are. The first and foremost is the incidence with which SICS is practiced. You can see it's almost a pizza pie type of a structure. All the incidences are varying from people doing less than 10% of SICS to people doing 100% of SICS surgery. So it's almost an equitable distribution. Coming to the anesthesia, again there are lots of variations, most common being the peribulbar, but also retrobulbar, topical, parabulbar, that is a posterior long subtenance, subtenance and subconjunctival are also used for MSICS. Coming to the site of surgery, the most common preferred site is superior, followed by the superotemporal and then the temporal. 9 surgeons are there globally who customize their site according to the toricity that exists. Coming to the various steps of surgery and which you have been discussing in the prior sessions also, superior rectus brittle suture, 93 do not use it anymore, 147 do regularly use it. And I experienced great pleasure in saying that out of those 93, I am one of them who converted to not doing a superior rectus. Conjunctival peritomy, again 11 have converted to a transconjunctival incision without doing a peritomy. Cautery also, there are lots of variations, bipolar, ballpoint, and there are few who do not use any cautery. Whether a capsular rhexis is done first or the tunnel first, again 215 are there who do a rhexis first and 63 is the other way around. I'll not go into all the numerical statistics because of constraints of time, but mainly showing you the variations that exist. Incision again scleral followed by limbal, and there are those who do a clear corneal also. Coming to the shape of the incision, again a myriad of variations exist. The most commonly performed incision is the frown incision, followed by the straight incision and smile incision, and there are others also with back cuts and V-shaped and all those. Coming to the size of the incision, it ranges from 3 millimeter and now of course 2 millimeter. This was done in 2020 early. So it begins from 2 millimeter to 10 millimeter with the commonest size being from 5.5 to 6.5 as we now know. 142 surgeons do consider the toricity while they make their tunnel with respect to the size and shape. 73 just sometimes consider it, and 53 are there who do not take into consideration the toricity. Side ports again, 23 never make any side ports, and out of those who do make, 205 make a single side port while 50 make double side ports. Anterior capsular staining, again irrespective of the type of cataract that exists, 111 always use a dye and 7 never use a dye. Anterior chamber maintainer, again 26 never use, while the others do popularly use the ACM. Again, there is a lot of variation with respect to the hydro procedures also. 2 surgeons do not use any kind of a hydro procedure. There are some who use only dissection, some who use only delineation, and 69 are there who do both the types of procedures. Capsular opening also, the most popular is the rhexis, followed by the can opener and also an envelope variation. The maximum type of variations exist in the technique of the nucleus delivery. You can see there is a myriad of variation. Most popular is the visco expression, followed by the use of vectis, again wire vectis, irrigating vectis, and there is fish hook technique, Blumenthal technique, slide and glide and spatula, everything. Coming to the IOL implantation, 37.1% surgeons do implant premium IOLs in their MSICS, using either injectors, not using injectors, doing visco implantation and doing hydro implantation. Again, coming to the closure also, there are those majority who always suture the scleral tunnel. Only 20 are there who never suture the scleral tunnel. And again, also coming to the conjunctival closure, it is again having lots of variations. Majority just oppose their edges. Some use a cautery, some use a suture. One surgeon uses a glue regularly. And regarding the side port also, some use stromal hydration, 2 always suture their side ports, and 31 just leave it as such. And again, regarding the end, the subconjunctival antibiotic steroid injection, 166 always give, 70 do not give. So there is a lot of global diversity with respect to the MSICS surgery, and it is important to understand all these variations, what variations exist and how they influence the visual and surgical outcomes, so that it can help us to perform better and teach better. Thank you.
Wonderful, madam. Thank you for giving that systematic review of literature. Thank you very much. I next request Dr. Pawan Kumar to please start his presentation. Before that, Purvi madam, apart from doing a do you have Dr. Pawan Kumar here? Okay, so we'll move on to next, understanding the economics of SICS by Dr. Jatinder Bali. Madam, just had one, I was a little curious about is, apart from doing the systematic review of literature, how can't we start the preferences and trends survey? I think it's very well commonly followed. Survey. The recent survey? It's not a review. Acha, recent survey. Okay, great. Wonderful. And are we publishing that in our GS? Wonderful. I hope everybody reads that. It's about the latest preferences and trends. Thank you, madam. Yes, Bali sir.
Thank you, sir. Thank you so much. At the outset, I want to thank the entire team of ISMSICS and AIOS for giving me this opportunity to talk to you about the economics of SICS. And I do not have any conflict of interest to declare, no financial disclosures to be made. This sounds like a presentation which is trying to sell refrigerators to the Eskimos. All of us already know, the economics of SICS, and we are not really going to gain too much by trying to convert the people who are already here. But we still have a talk on this. So the question that arises is why, right? So to answer that, I'll just go through 2 or 3 important statistics. Cataract extraction is one of the most common surgeries performed worldwide. The policymakers are interested in knowing the most cost-effective way of employing the resources. And there is very little data that is published on healthcare economics aspects of manual small incision cataract surgery. Now, we did a survey, and which is yet unpublished, and we've come across this, that 75% of Indian ophthalmologists are practicing phacoemulsification, but 83% are practicing manual small incision cataract surgery. So if you look at those data points, we have around 17,000 data points. And the data, and everybody sitting here has data which is available to him. He does not need to go out and reach out to any institution. He can use his own data to get published, does not require any ethical approvals for it, and is not dependent on any of the institutions. We have Dr. Gogate, and we have some luminaries here who worked in this field, and they are making their services available. We have the IGO special issue coming up on this. And the purpose of this talk is to exhort everybody to use their data and publish it. And that is what we're trying to do is, what we'll try to do is we'll just sensitize you to it, and we'll help you reach out to people. We'll give you some templates, and you build it up from those templates, right? So the first thing is, whenever a new procedure comes in, first thing we do is we do the outcomes. What we'll do is, what is visual improvement, astigmatism, complication rate, that's the outcome description right on top. Can I have a pointer? Okay, so the first, Okay, so first thing we do is outcome descriptions. That has already been done. Then the cost descriptions.
You can use the cursor if you want.
Okay, yeah, I think that's much better. Okay, so first thing is the outcome descriptions. Then we have cost descriptions. कितना खर्चा आएगा उसके ऊपर. Then we link the cost to the outcomes. And then we do some sort of a cost analysis. Now these steps have been done. And then we do a full economic evaluation. When we do full economic evaluation, there'll be many terms that will be thrown at you. If effectiveness of two techniques is absolutely same, right? Then the one which is cheaper, that is cost minimization, which is cheaper is definitely better. And at the other end of the spectrum is cost benefit analysis. Now what the policymaker wants to know is, he will say that convert all your benefits into monetary terms and then give us cost is a monetary term and then the benefits are monetary. We are not very happy doing that because there are a lot of assumptions which are there which would be coming in, and we don't really want to make so many assumptions. So we want to use some of these techniques in between, which is cost effectiveness and cost utility analysis. And one is, of course, mortality, morbidity indicators, but then the question that arises is what are we going to use in small incision cataract surgery? I'll come to that later. Cost utility analysis measures it in quality of life years adjusted and DALY and QALY, right? Now, why we're talking about it today is because a very famous study called FEMCAT has just recently, it was a French multi-center participant masked randomized superiority cost effectiveness trial, which compared femtolaser with phacoemulsification, and it said that FLACS, that's femtolaser assisted cataract surgery, was not, when you use femtolaser, you have to spend 10,700 euros for every patient extra, for every patient to get the same result, which you can get with phacoemulsification. So that is something called incremental cost effectiveness ratio. That is the cost difference to the effectiveness difference. This is part of the full utilization analysis, and what we have done is, so now the question arises is, what are the endpoints that we can use? Sir, I'll take just 1 minute, right? So we can use costing analysis, we've already, all right, so what are the endpoints we can use? It is, the complications at the end of 3rd month, best corrected visual acuity 6669, absolute manifest refractive error which is left of say less than half a diopter or whatever we can decide, and postoperative astigmatism of less than half or 1 diopter. And complications, we've got a list of complications which you can see from here, which can be utilized. Costing analysis, there is a list, you get a check, there is a checklist, and you fill in the data from that checklist, and that gives you a complete costing analysis. Broadly, costs are of capital, labor, material, and operational costs. So depending on the data which you have in your practice, you add all of it. And then there are these studies, most famous one being this study from India, which compared $15 for small incision to $42 for phacoemulsification. And in Thailand, there's this incremental cost effectiveness analysis, which has come $62 to $104. And these are the different methods of evaluating it which are available. So what I will request all of you to do is reach out to your local ISMSICS chapters. And Sir is here, Dr. Boramani is here, Dr. Sahu is here. And what we'll do is we'll put out these templates, and you can utilize the templates. You see, all these data points are with you. You have your costs, you have your clinical outcomes. And this is data which is of immense value for policymakers. So the decision to go forwards lies with all of us here. I hope, if we manage to bring out even 40, 50 papers out of this, I'll really be happy. Thank you so much.
We'll take your suggestions, sir. Thank you so much. Next, call upon Dr. Jagdish Reddy Bandi to please speak on the Global SICS training program. And after that, I request Dr. Aman Khanna to please be ready.
Good afternoon, everyone. At the outset, I would like to thank the AIOC committee and the ISMSICS for giving me an opportunity to talk over here about the new things which are happening in the global SICS training platform. Absolutely no financial disclosures. So the training program actually has main components, 4 of the main components, which are an iCoach, interactive video rooms, tele-mentoring, and a matching program. I'll talk to you about these in detail a little bit. What is an iCoach? iCoach is basically like an Udemy or a video learning platform, which actually is exclusive for only eye surgeons or ophthalmologists as such. One of the first training videos which was released on this platform belongs to ISMSICS. It's called an M6 training module. This M6 training module is basically oriented all for the young surgeons who want to develop their skills. The M6 module is perfectly tailored for you, and it has basic, intermediate, and advanced speakings or videos which could guide you through the sessions. We have more than 100 speakers covering over 140 topics, exclusive for this M6 training module. All of them were or will be online soon. And this also comes when an individual or a new student actually goes in and tries to get all these videos. He would actually go through a few quizzes and so on and would get a certification. The best part of it is it's all free for the members of ISMSICS. And we can also integrate this course. This is basically an online course. If you have a training program in your hospital or an institute, you can get the knowledge based from this. The live program runs at your place, but the knowledge or the certification program, you can go through the global SICS training program and can get the certificate for your student or the person who is doing it. The next, interactive video rooms. What exactly I mean by interaction? Interaction is basically, let's talk about a traditional way. When probably 10 or 15 years ago, when a student actually, when a teaching institute is trying to teach a student, he probably stands next to the master and probably sees through the observer microscope and so on. As time passed on, this traditional system has passed on into something like probably a video on a TV screen where a group of students actually see it. Now, this same video which the students are seeing and interacting, it's gone a little further. You actually have the TV in the next room, and probably the person who is actually doing the surgery actually has a microphone and who talks to the students outside. So now cut these wires and you have your students not just outside the room, but not only in your local locality, outside the country, globally. So one world, one class is the motto for this. So we want to actually use this software to actually, for example, you have a live surgery which is interesting or a presentation which is interesting. You send out a request to a defined group of users, whoever are interested in this, and then at that particular onset of time, you would be able to transmit it live for all these people. So the queries can be both ways. It can be either if there are a lot of people, you don't want a lot of people talking together, so you can use it. The queries can be used either be voice-based, they can ask you, or it can be text-based, and then you can reply them by voice. So what do I mean by tele-mentoring? The word itself says tele-mentoring, mentoring from a distance. So during the pandemic, you would have seen that most of the people who are doing surgeries, if they need some kind of an assistance or something, or if you have one of your mentor who is outside the city or who is far off, you just don't want him to really do the surgery, but you want him to see your surgery and guide you through whatever it is, probably like giving you a few tips and so on. So you can actually be able to transmit your video, and by actually having your earphone on, you would be able to take some of the few instructions. I'm not saying you can complete a surgery just like that, but you can actually get a few instructions to that. What do I mean by an offline module? You can make a video of whatever you have done, upload it, and the reviewer or the expert person would actually review it and actually talk about it. Maybe you had gone, there was a PCR, you want to know why it happened, at what stage it happened, you just want to get clarity, or you have a technique which you want to tell to someone or refine yourself, you can go through the offline module. So the next one, I'll talk about the management, recessive man. We are pretty much clear that SICS is probably, the training is the best in India compared to any other countries and the largest. So we have all these institutions over here giving out programs, each one at their own schedule, and there are students not only in India, all abroad, who would be interested to actually take these courses. So we're actually trying to refine the system where an interested SICS student can actually match with the slots available all over the country, and then we could successfully match so that a training program can be taken care of. The web-based version, the videos also can help them during the training program. A certification also can be helpful.
Thank you, Dr.
Thank you,
Jagdish.
thank you so much. And,
yes, sir. Till then, I request Aman Khanna to please load his presentation.
See, let me tell you, these people who just stand up. We are launching the journal and we are launching the SICS training program. Stand up. These people have spent sleepless nights to make this program successful. And Jagdish is our technical director, and he's a silent worker. We have supported him, harnessed him, and he has been really, we are enjoying him thoroughly. Okay, I just wanted this moment, everybody know that these are a talent we are looking for. Whenever we see a talent, we just make sure that they come forward. Okay.
The unsung heroes.
And they have a team of many hard workers working with them.
Yes, go ahead, Dr. Aman.
A very good afternoon to everybody, and thank you to all for giving me this opportunity. So today I am going to present a case of tackling a hard cataract colobomatous eye, and how the knowledge of basics can save your day during the surgery. So this was a hard brown cataract and with a typical iris coloboma, and we decided to take the case up for phacoemulsification. And all the routine steps for phacoemulsification were being done. The rhexis was made slightly a larger size rhexis because it was a very hard nucleus. So after making the rhexis, we did a hydrodissection, and the nucleus was full freely mobile. And we started doing routine phaco in this case. So a deep wide trench was made, and everything was going fine. Then suddenly we noted that the pupil has started coming down, and the pupil was getting smaller. So now I was trying to, in a urgency to complete the case before the pupil gets small, I just took my phaco probe towards the periphery, which should actually not be done, and was trying to chop the nucleus. And here at this point something went wrong, but I was in only a mindset of just completing my case, so I didn't notice that something was wrong, and the movement of the nucleus was not very free. So I decided to chop the nucleus. Then again, even at this point, you could see there is a PCR centrally, but I again missed it, and was pretty engorged in just emulsifying the nucleus and finishing the case fast. And you can see the microscope is also not very well centered. Yeah. So now after emulsifying these two quadrants, it was at this, sorry, yeah. Now again there was very much resistance in the movement of the nucleus, which I noted, and I didn't pay attention to that during this point. So again the nucleus was removed, and I emulsified another quadrant. And it was at this point when I noted, you can see there is a large central PCR, and I was lucky that I didn't had a drop in this case. So at this moment when I noted the PCR, I decided to bring the piece, both the quadrants into the anterior chamber. So after getting these quadrants into the anterior chamber, I decided to convert the case to SICS. So frown incision was made, as the nucleus has already been broken, so I didn't need a very large channel for this. And at the end I was able to successfully remove out both the pieces of the nucleus, and you can see this was a very hard nucleus. And so after that anterior vitrectomy was performed, and with a good cortical cleanup. Yeah, and at the end of the surgery I was able to implant a 3-piece IOL in the sulcus, and optic capture was done. You can see there is ovalization of the rhexis, which was achieved here, and the aisle was centrally placed at the end of the surgery. So the lessons learned from this case, that good visualization and focusing is very important. Keep your eyes open. Early detection and timely management plays a very important role. And to finish that, do not panic. Whenever going gets hard, just stick to basics. So in this era of phacoemulsification and SICS, SICS is, MICS, SICS is a surgery which still holds its fort strong. Thank you.
Thank you so much, Aman, and good that you showed your complicated video. That's what we would like to know about it so that we can learn more about it. Thank you so much. Now the audience will stay because it's the Magic 2 going to start now. I request the chairperson, Dr. Sahu sir, to please come over to the dais, and Subuddhi sir will stay here. I request our dynamic moderator, Dr. Parikshit Gogute. Sir, please requesting you take over. And Dr. Sabyasachi Patnaik.
Yeah. Meanwhile, I request delegates, if you feel that this hall was very small for SICS,
yes,
kindly send your feedback to AIOS. You can write the mail also to Chairman Scientific Committee so that we can get a bigger hall in the next conference.
I have already done that, sir.
Very good. Thank you.
Yes, sir.
Boramani, sir. Thank you. Thank you. I thank the chairpersons, Dr. Debashish sir, Dr. Prakash Marathe sir, and Usha madam for conducting it so well. Thank you.